Welcome back to Your Health television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon, and I'm delighted you could be with me for this next segment. It's my honor and pleasure to talk about mini lifts, typically that we do in the office. As you know, I'm a board-certified plastic surgeon, and very frequently, especially in more recent years, I have seen a lot of people come into my office who are interested in having a procedure in the office. So I think it's important that we talk about this very important issue about locating the best place for your procedure. There's a phrase that we use in plastic surgery and in surgery. It's timing, location, and anesthesia. Those are important parameters that we need to decide and make wise decisions about. So what I'd like to do is take a couple of minutes to talk about the choices that people have regarding location and anesthesia. So to start, what happens when we do a procedure in the office? When someone is of good health and of the proper mindset to be able to be numbed up with a needle, in other words, have a local anesthetic infused or injected, when someone is healthy enough for that and is ready and able to have a procedure in the office, someone comes into the office. They're checked. Of course, we make sure there's been no change in their past medical history or physical exam since their initial consultation. And of course, everyone gets a consultation with me who is considering having plastic surgery with me and in my practice. Everyone gets a history and physical. So people come in and we confirm the medications they're on. We check to make sure they don't have allergies. We check their vital signs, and that's important. We have a little monitor in the office called an oxygen saturation monitor. We can check the saturation in their blood, the percentage of the blood cells that are bound to oxygen. We check their pulse and their blood pressure, etc. So people come into the office and they can take an oral sedative by mouth. That's a pill. Take an oral sedative, an oral narcotic, and an oral antibiotic. Now those medicines, it sounds like it's simple, but I do want to emphasize that an intravenous is not started. Those are pills, an oral sedative, an oral narcotic, and an oral antibiotic. In the office, after checking the consent forms and making sure the paperwork is all taken care of, etc., we allow those oral medicines to take effect, and that might take 20 minutes or so. Once the oral medications are administered and they start to take effect, we can then numb up the skin for whatever procedure someone's going to have. So we numb up the skin with a needle, and that can sting. Many of you are familiar with going to different doctor's offices and dentist's office and getting a local block. Something like lidocaine or xylocaine is used. I like to use a medicine called Marcaine, which is bupivacaine, Sensorcaine. That's a much more long-acting local anesthetic. So we numb up the skin and we let that take effect. We wait for a few minutes. Once the skin is numbed up with a needle, then I can infuse a very dilute numbing medicine into the deeper tissues called Hunsted's formula or tumescent formula. For example, let's say someone is coming in for a mini cheek lift, mini facelift, or even a mini neck lift. Someone will come in and checking their vital signs and their oxygen saturation, etc., they can get the oral sedative, oral antibiotic, and oral narcotic, and after that takes effect, we can numb up the skin. And again, that's with a needle. It stings, but then it makes the skin entirely numb. We allow that to take effect. We make a very mini access incision when the skin is numb, and we infuse in Hunsted's formula, tumescent formula. It's a very dilute numbing medicine with a buffer and a vasoconstrictor. Helps the blood vessels constrict so we minimize a person's incidence of blood loss or bleeding. We don't want any of that to go on in plastic surgery. So the end result is that someone is relaxed or mellow, numb, but awake. Now it's true enough that sometimes during a plastic surgery procedure in the office, a person will fall asleep, but it's not because they're under a general anesthetic or an intravenous sedative. It's just because they're relaxed and they're numb. Sometimes we have pleasant music playing, and they're laying down. And like, oftentimes, like some people when they go to the dentist or they go to the doctor's office or etc., they're just relaxed, and so they take a nap while we do a procedure. But it's not a general anesthetic. Now, the next level would be going to the surgery center. And we're fortunate that I have a surgery center, Monterey Peninsula Surgery Center, right on the ground floor in my building here on Monroe Street in Monterey. So what happens when someone comes into the surgery center? An IV is started, an intravenous. That's what an IV stands for. That, of course, is after the paperwork is checked and taken care of and the consent is signed and their vital signs are rechecked, etc. Very similar thing. But after that, the IV is started. Then, before the operation, those same 3 medicines are administered. The sedative, the narcotic, and an antibiotic. Those are administered right in the vein, and a patient has the opportunity to tell the anesthesiologist how deep they want to go. So when I say how deep they want to go, they can totally take a nap. That's considered to be a general anesthetic, and there are, of course, degrees of that. There can be a deep general, there can be a light general anesthetic. Sometimes a person will be anesthetized to a depth whereby the anesthesiologist is actually supervising the breathing and the respiratory status for a person with a machine, a respirator. And so that's considered to be a fairly deep and general anesthetic. A little bit lighter anesthetic is when the person is essentially taking a nap, but they're breathing on their own, and they're being monitored and they're stable. So another level would be sort of twilight anesthesia, where someone is sort of half asleep, half awake. There can be heavy sedation, light sedation. Sometimes what we do is just give a person a very brief dose of a fairly heavy anesthetic in a controlled dose so I can numb up the skin. For example, if a person just doesn't want to feel the discomfort associated with the needle numbing up the skin, we can give them a very short, semi-general anesthetic for about 60 seconds or 90 seconds. We can use the needle to infuse the local anesthetic, and then by the time the 60 seconds and 90 seconds is up, they're coming to and they're numb. So they avoid the discomfort of that initial numbing of the skin. So, and again, of course, I can numb up the deeper tissues under the skin with Hunsted's formula. But at the surgery center, an intravenous is going. There's an anesthesiologist there, as well as a circulating nurse, sometimes 2 nurses, a surgical tech. And it's just a higher level of monitoring, more involvement. An intravenous is started, and you can choose the anesthetic you want. Now, the next location or the next level would be at the hospital, Community Hospital of the Monterey Peninsula. At the current time, I'm chief of the division. And typically, people will have a general anesthetic, always an intravenous when we go into the operating room. You can have what's called a monitored anesthesia care, or MAC, where a person can be heavily sedated, almost asleep, and I can numb you up, etc. Or we can just tell the anesthesiologist that you want to go to sleep. That's a general anesthetic. As heavy as you want to go, you can be connected to the respirator, etc., and we can operate. Now, how do we choose? How do we make the choice? Well, first of all, I want you to know something about my practice philosophy. I think that there are 4 important parameters that we need to pay serious and particular attention to. The number 1 parameter is quality. Of course, regardless of whatever we do, I'm very dedicated to administering the highest possible quality that we can, a very high standard of care. Number 2, safety. We need to pay attention to safety. We need to commit to safety. Sometimes I say safety first, but I think quality and safety are certainly 2 parameters that we never compromise on. We follow the rules, we follow the regulations, and we never compromise quality and safety. We always want to dedicate ourselves to that. Thirdly, we need to build goodwill in the community. I think that what that translates to is having people, instilling the feeling with people that we're dedicated to their comfort and safety and high quality, that they feel they're being tended to and listened to, and we pay attention to them, and that we have their best interest in mind. So number 1 is quality, number 2 is safety, number 3 is building goodwill in the community, and number 4, of course, is economic viability. It needs to be affordable for all concerned. It needs to be viable for all concerned. And whether it's an insurance case, a reconstructive case, or a cosmetic surgery case, it has to be affordable for the employer and the patient and the doctor and nurses and facility and the hospital, the surgery center. People have to get paid. We have to meet our expenses, etc. So that's important, economic viability. And certainly there's a difference in price and cost and charges between the office and surgery center and the hospital. I don't think that's the most important parameter, but I think oftentimes we need to, of course, compare and do the best thing for the patient, but we never want to sacrifice quality, safety, and we certainly want to commit ourselves to building goodwill in the community. So, to back up again, how do we decide about these issues: timing, location, and anesthesia? Well, first of all, in the office, I've described the scenario where someone comes in and gets pills, an oral sedative, narcotic, and an antibiotic, and gets numbed up. Then we infuse the numbing medicine for the deeper tissues. That's for the person, first of all, who has the mindset that they're okay with being numbed up. Now, certainly the needle stings, but then someone goes numb. Now, I'm not judgmental. I think that people have a choice. We need to listen to people about where they want the procedure. I think it's important that we go over realistically what the options are. It's very interesting in my practice that I will see people in my office, I'll meet people who say things like, "Oh, Dr. Morwood, I don't want to be asleep. I want to be fully awake, and I just want to be able to respond, and I don't need to have a general anesthetic." Perfect. If that person is amenable to getting numbed up, let's schedule a procedure in the office. If their medical condition is good and their medical doctor gives us the okay, and it's a relatively shorter procedure. I don't like to go more than 4 hours in the office because people tend to sometimes want to get up and take a break, or they want to go to the bathroom, or they want to get a sip of water. So in general, nothing more than 4 or 5 hours because they're sitting and laying down. But they just need to be of the mindset. Now, I also, as I said, I'm not judgmental. I also have people who come in and they say, "I don't want to see a needle. I don't want to hear about what you're doing. I don't want to hear about what you're talking about. So please start an IV at the surgery center or hospital and put me out." Or they might say they don't mind being awake after the local anesthetic is infused, and that's okay with me. Other procedures that I may do at the surgery center or hospital, any type of implant like a breast implant, I want it to be a super sterile environment. Certainly in the office, we have plenty of betadine, which is an antiseptic. We have a great autoclave. I have great assistants, sterile drapes. As I said, sterile instruments, etc. But for implants, we tend to go to a more super sterile environment like the surgery center or the hospital. Now, it's possible to stay overnight at the surgery center, but we tend, when people want to stay overnight, to do that operation at the hospital. Also, longer operations are done at the hospital if we want other doctors and nurses around. If someone has medical conditions that may be a little bit fragile, we'll probably do that at the hospital if we need or want other doctors around and nurses. Sometimes an internist will tell us that they prefer a person has a general anesthetic at the hospital, which is fine. Sometimes we will do a combined insurance and cosmetic operation, and typically that's done at the hospital, sometimes the surgery center. But again, a person has choices to do an operation in the office, the surgery center, and in the hospital. Examples of what we do in the hospital: certainly we do our fillers and Botox. We do small areas of liposuction in the office. We can actually do fat grafting, small areas in the office. We can do upper eyelids routinely, sometimes lower eyelids, sometimes mini facelifts, cheek lifts. We can do mini neck lifts in the office, lateral brow elevation. I sometimes do lumps and bumps and simple hand surgeries in the office. The surgery center, as I said, is for longer operations or for people who want a general anesthetic or more sedation. they'll get an intravenous started. And a hospital, of course, is for more complicated things, if I need more complicated equipment, supplies, etc. So we're very lucky that we have choices here in Monterey. Once again, I'm Dr. David Morwood. I am a board-certified plastic surgeon. I'm here in Monterey. If you have questions about a plastic surgery procedure being done in the office or surgery center or hospital, I'm on the web at www.drmorwood.com. That's D-R-M-O-R-W-O-O-D. My office phone number is 831-646-8661. We'd be delighted to see you in the office. Just please call for an appointment and consultation. Everyone who has a consultation I meet with personally. Dr. David Morwood, board-certified plastic surgery here in Monterey, California. And this is Your Health television program. Thank you very much for viewing today. I hope you tune in again soon.